All right, so we're at about the start time for this session. A few people are likely to trickle in, but as they are, I'm going to go ahead and start the introduction to this session with Claire Leather. So welcome to the session of the 2025 Culture of Data Conference. Thank you all for joining us. My name is Maya Contreras. I go by she, her, and I will be moderating this session. We also have Taylor Bostick, she, her, who is managing the Zoom and making sure the tech is running smoothly. You are all muted now, but if you have a question during the Q&A sessions, please feel free to unmute. You can also use the chat box if you have questions or need anything. If you are comfortable doing so, please add your pronouns to your Zoom name by clicking the three dots on your video square and selecting rename. During this session, we have one presentation. They will present for approximately 25 minutes, and then there will be about 10 minutes for question and answer afterward. I personally am really excited to learn from this presentation in Colorado, where most of us are, and where most of us are, we have all likely experienced the wildfire season and its wide-ranging impacts, including the health impacts of toxic air quality. And so I look forward to learning more about the health disparities and social vulnerabilities associated with wildfires and ozone spikes. Very timely research. And so now I will turn it over to Claire Leather to present disparities in emergency room utilization during wildfires and ozone spike events.
Thank you so much, Maya, for the introduction. I am excited to join you all this afternoon. I am the Public Reporting Program Manager at the Center for Improving Value in Healthcare. And before I get into the analysis, I do want to share a little bit about my organization for those of you that might be new to us. So the Center for Improving Value in Healthcare, or CIVHC for short, was formed out of the 2008 Colorado Blue Ribbon Commission on Healthcare. Our mission really is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data to improve healthcare and health outcomes. Our vision is that everyone has the opportunity to be healthy and have access to equitable, affordable, and high quality healthcare. And we as a nonprofit pride ourselves as being independent, objective, and service oriented. So who we serve a number of different audiences and partners in the healthcare space. And we call these partners our change agents, which I'm guessing are many of you on this call right now, on this webinar. These are the folks that are in the trenches working to improve care in Colorado, lower costs, and these folks touch on nearly every aspect of healthcare. So they can be clinicians, hospitals, employers, nonprofits, researchers, consumer advocates. We get to work with them all. And at the center of all of our work and what sort of unifies us is the consumer. So that is who we are serving, and that's really important for us to be aligning ourselves with service-oriented organizations and individuals. So how we serve, the most important way we serve is that we are administrators of the Colorado All-Payer Claims Database. And in being that administrator, we release public and non-public data. So today we're going to be talking about public data. So this is data we provide to the public to identify opportunities, areas of improvement in our communities. And this data is provided via interactive reports, publications, Excel files, infographics, all that good stuff. We also provide non-public data, and those are released to those change agents that license the data from us to do more specific project needs. I'll share some of those projects as it relates to this topic later on in our conversation, but they really have a specific research topic and they come to us and request very, very specific data. Additionally, we have some additional support services. We do research and evaluation services for a lot of direct service organizations. We have programmatic focus areas in advanced care planning and palliative care, and we do community engagement. If you have any healthcare data needs or thoughts or desires, or yeah, just come to us. We're happy to discuss and share what we know and what we have. So this is really good baseline slide to sort of get us into analysis. This is our data source. So like I mentioned, we are administrators of the Colorado APCD, the All Payer Claims Database. So what exactly does that entail? Well, it entails about, it includes medical, pharmacy, and dental claims data going back all the way to 2013. And this totals more than a billion, 1.1 billion claims and counting. So we get claims in every month. So this number is always growing. So it's significantly more now than when this slide was created. But that looks like 49 commercial payers, including 100% of Medicaid and Medicare fee for service. We also get Medicare Advantage. That looks like about 74% of the covered lives in the state. So that is about 5.6 million people. And again, that is as of 2023, excuse me, and that reflects medical coverage. Just as important to note is what's not included in the Colorado APCD. So federal programs such as VA, TRICARE, Indian Health Services are not included. Majority of ERISA-based self-insured employers are not included. And then the uninsured and folks that self-pay. So we do not get those claims in our database. So just a good level setting to understand kind of our data source. So let's get into the topic. Many of you probably already know this, but climate change is accelerating the frequency and the intensity of wildfires. And in Colorado, our drought seasons have lengthened, and increased heat have led to like significantly longer fire seasons. And that looks like an average of 5,000 reported fires yearly. And this is important for healthcare because wildfires increase both the particulate matters, PM2.5, and ozone. And when they are mixed together, they create a toxic air quality for us. And that can persist even far from the fire sources. So when talking about respiratory and cardiovascular stress, ozone is a potent irritant. It can exacerbate asthma, COPD, and other lung diseases. Wildfire smoke contains fine particulates of PM2.5, and it can penetrate deep into the lungs, increasing the risk of heart attacks and strokes. Combined exposures can lead to more ED visits and hospitalizations, and this is kind of sort of the background when thinking about this project and the importance of this kind of analysis. So the impetus of this study came from a legislative request. So as a nonprofit, as sort of stewards of this data, legislators often come to us to get some unbiased data to help them create legislation, monitor legislation, inform potential policy. And this came from a representative who was on the wildfire subcommittee on health. So the purpose of the study is multi-pronged. The first one is to investigate the impact of air quality on the emergency department visits. We wanted to provide some data-driven insights to inform legislative and public health discussions. And we really wanted to support the general public's understanding of the health impact of spike pollutant events. So study design. So key pieces to our study design. We looked at data from 2018 and 2019 because for two reasons. There is a high frequency of wildfires in those 2 years. And we also wanted to stay away from COVID years. As many of you who have done any research recently can attest that the COVID years can skew our data, and especially given the diagnosis codes that we are looking at, may make things murky for us and create a confounder that we really didn't want to deal with. So we stayed away from those years. We isolated the costs and utilization of ED visits for a principal diagnosis for respiratory and cardiovascular conditions. So what that means is if someone comes into the ED with a broken leg and they're also have bronchitis, the primary diagnosis is going to be the broken leg, and the respiratory diagnosis will not be included in that in our report. So that person, that member, that claim isn't included in this analysis because their primary diagnosis wasn't the respiratory or cardiovascular condition. What else? Air quality data from the EPA for wildfire and ozone pollutants was included. And then to provide sort of further context about what was happening in the state during those years, we got public wildfire data from the Colorado Division of Fire Prevention and Control. So for us, a spike in wildfire particulates was PM2.5 concentration of 35 micrograms per cubic meter or greater. This is just, the UG is just the unit of measurement for air pollution concentration. Our spike of ozone particulates was 0.070 ppm or greater. Both thresholds come from the EPA's air quality index and are recognized by many different kinds of organizations. Some additional variable details that we ended up reporting on. So diagnosis codes for respiratory and cardiovascular diseases are grouped together by AHRQ clinical classification system. These classify ICD-10 codes. We looked at county and statewide total volume of ED visits for respiratory and or cardiovascular disease, and county statewide incidence per 1,000 was our rate. We looked at total cost. We looked at cost per visit. The insurance types that were included in this report was all of them, basically. So we looked at all payers combined for the utilization measures, and then broke it out by Medicaid, commercial, Medicare fee for service, and then Medicare Advantage when we are looking at cost. Geographic area, so statewide, is what we looked at for the cost measures. And then for utilization, we looked at counties with EPA monitoring sites. So important to know, and I'll touch on this again when we talk about limitations, not all counties have an EPA monitoring site. So out of the 60 to 63 counties in Colorado, we have about a little more than half have the monitoring sites. And we also reported on age breakout. So limitations and exclusions to this analysis, only Colorado residents were included in this analysis. So folks who sought ED care with the similar diagnosis codes were not included if they were not Colorado residents. This analysis does not include Colorado folks that are in the APCD and or claims that do not have a member county data available. So we do receive claims without that information. Given that this is very specific to county level data, we did not include anyone that did not have that information on the claim. And then this analysis is limited to the Colorado counties and months that had available EPA data for wildfire and ozone in 2018 and 2019. As I mentioned, the EPA does not have monitoring sites in every county. So let's talk about the findings. High level, just to sort of get your head around sort of the impact of this. There is over $1 billion cost for ED visits for respiratory and cardiovascular diseases per each one of these years. And while all of these cannot be attributed to poor air quality, the scope of the cost, I think, is really, really important to understand that we're serving a lot of people in our hospitals, in the ED, the most expensive place to get healthcare for these diseases. And so I want that to sort of be in the back of your mind when going through this data. So this map shows where we saw spikes in ozone and wildfire concentrations. And you can see here that all counties that had a spike from wildfire concentration also had a spike in high ozone concentration. So that's important to know when thinking about the relationship between ozone and wildfire. Pollutants, these counties were Adams, Boulder, Denver, Douglas, El Paso, La Plata, Larimer, and Weld. The counties in green were 36% of the counties that we looked at. And they were the ones that had high ozone concentration in general. So a large number of counties experiencing spikes in either wildfire or ozone particulates that are not sort of safe for, that might pose a health risk for folks to breathe. Some more general findings, there's a seasonal variation. So we know that anyone in healthcare knows that there are increased times of year when folks are entering the ED. So that could be weather, allergens, and cold and flu season. So that's something to keep in mind. We also found that their air quality may exacerbate jumps in incidence, especially for the young and elderly. So this is the key piece of our finding, and it goes into the age group vulnerability that I'm going to talk more about for both particulates. So in 0 to 17 and those over 65, we found that for both types of poor air quality impact, we saw an increased incidence in them using the ED. Now for 0 to 17, that age group always has a higher ED visit rate than anyone else, regardless of air quality. So that's an important general finding to understand. Now, wildfire. So this should say 2018 and 2019. Our findings were that higher rates of ED visits in counties during months above wildfire air quality threshold. So we saw that in particular for vulnerable groups under 17, adults over 65, there were higher ED visit rates. So 6 out of the 8 counties, 75% of those counties impacted, you could see the spike in ED utilization in the months that had particulate matter over that threshold. So important to note that there were 3 counties in particular that had repeated occurrences of higher ED visits compared to the rest of the state when there was wildfire pollutants in the air. Denver, La Plata, and Weld. So this suggests to us maybe there's some geographic areas where air quality could be even more of a significant concern for age groups. So not only are these spikes happening, they're happening relatively in repeated occurrences in these counties. Now shifting to ozone. So base level average ED visit rate per 1,000 covered lives or per 1,000 people across all months when there is a spike is 1.8 for all ages. It's 3.1 for 0 to 17, and then 65 plus, it's 2.0. So that's kind of the baseline. Over the entire year, this is what the average was. Now, what we found in our analysis is ED visit rates more than doubled in winter months when we went above that ozone threshold for those counties. So we do normally know that, children and youth, seniors might be utilizing the ED more, but when looking at peak pollutant periods, particularly in the winter when people are already getting sick, we see this spike. So that doubles, right? So you're seeing the blue bar, that's children and youth. So you're seeing 18 visits per 1,000 lives versus 7.5 when in winter months below that ozone threshold. And then a very similar trend with our seniors, 7.6 in the winter months above the threshold versus 3 winter months below that ozone threshold. So for us, what we're thinking is there is an exasperated that could be happening for these folks, right? So they're already experiencing health concerns, and then the air pollutant level gets really high, there's a spike, and then they need to go to the emergency room more. So this is our chief finding, very interesting. And so why is this all sort of matters and important? And age disparities we have found that are often healthcare disparities in general often focus on race, income, and geography, but age is sort of critical and sometimes can be an under-discussed factor. Children and seniors are biologically and socially more vulnerable to health stressors, yet age is often generalized or lumped into some broader population metrics that might not make sense. And we think that we've seen sort of failure to stratify data by age sort of obscures the unique risks and intervention opportunities for this population. You know, we ran this report a couple times and we really this was sort of found when we kept digging into our methodology and kept sort of making changes to see what else could be happening in this population that shows some disparities. And so even for us, we had to go back to the study design and look at how we were conducting things to make sure that we were stratifying by age as to not blur or sugarcoat the actual issues at hand. So 0 to 17, you know, health risks are often underestimated, the healthy child bias, but there can be long-term consequences for early exposure to these air toxins and air pollutants that can be overlooked in policy and emergency management, all those things. 65 and older, you know, this group is elderly, they're always considered, you know, they have all these ailments anyway, so they're sort of put to the side. They're face barriers themselves with mobility, fixed incomes, and chronic disease. And then obviously there's rapid population growth in this age group. So when thinking about public policy, public health interventions, and thinking about the fact that we do get more wildfires, these two age groups in particular should be the focus of policy interventions, given that they are the ones using our healthcare system the most when these things happen. So again, both groups are seen as dependents and not always active participants in health systems. And this can lead to sort of insufficient responses to their needs. Next steps for the analysis is obviously we limited this this analysis to ED visits for these specific conditions. We are thinking of getting even more specific and looking at bronchitis, looking at asthma, looking at really specific cardiovascular incidents to really see if there is what kind of strength that relationship may have between air pollutants and these visits. We did not do an extensive regression or correlation analysis, so that's something that we would like to do. We are also thinking of looking at, you know, what increases in primary care, urgent care, telehealth visits happen around these events. And then we would like to eventually do some evaluation of the prescription drugs that are filled for asthma and respiratory conditions around these events to really understand what the whole, how people are getting treated when something like this happens in their communities. And as I mentioned earlier, we license our data as well. So researchers at CU have studied sort of environmental impacts of living near oil and gas sites, and they found that there was strong evidence in older adults and women with AFib, and their symptoms worsening and their conditions worsening as the developments of those sites happen. Colorado Public Radio did a study on, did a report on this, excuse me, and they linked the study. So I encourage you all to look at that. And then additional studies using Colorado APCD data. There are researchers who looked at the prevalence of asthma in 6 to 7-year-old children in Denver County, you know, knowing what we know about the air quality in, in that county. And then another study looking at the health impact of living near rocky flats. And so those were all out there and very interesting as well. To access the full data set for the analysis I've been talking about, you can visit our website, civic.org, get data, publications. We just ask that you fill out a short Google form so we know what your interest is and sort of who you are. And then we will send you the data set and you can play around with it yourself. It's rather robust, as you can imagine. There's a lot of data points in there. So that's all I've got. Questions and feedback. Would love to hear from you all. This is my email. If you want to follow up after this, you can also find us on all of these places. And I will just plug, as the public reporting program manager, we have a ton of data available out there in the world, population health data, cost and utilization data. We have some really interesting equity mapping data as well. And I just encourage you all to go to our website and poke around and just have fun and see what you can find. So yeah.
Thanks so much, Claire. We can go ahead and move into Q&A time. So if you have a question, feel free to just go ahead and unmute yourself. But if you don't feel comfortable doing that, you can drop your question in the chat and then I will read it for Claire. You can go ahead and pick us off. There's so many interesting lines of inquiry within this presentation. But the one that sticks out to me is the decision to separate out by age. And I felt like the reasons that you gave were really compelling, but I was just curious if in the future you would look at the interaction between age and race or age and
Mm-hmm. Mm-hmm.
socioeconomic status and
Mm-hmm.
just sort of
Yeah.
maybe you could speak to the future plan of the
Yeah.
research or like the
Yeah.
decision-making process of that.
Yeah, sometimes in a public report we're limited, especially when the request comes from a legislator, in the scope of what we can and can't do. And so we kind of had a pretty specific scope, but like I said, we're really interested in saying, we're like, are we missing something? And I think race and ethnicity, and I think socioeconomic pieces, we are really fortunate that all of our data is actually geocoded to the census tract level. And what we can do with our data is we can marry it with the American Community Survey. And we can pull ACS data and we can kind of see what those relationships are, what's happening more closely. So that is something that is always something we want to do. It's a matter of just time and resources because we have done that in the past. We have something called health equity map that shows health outcomes and disparities across Colorado communities at the census tract level, looking at all kinds of social determinants of health measures. So for something like this, I actually do think your point, Maya, is pertinent because um, I think we would find which is what we found in other reports, that neighborhood by neighborhood, we probably would see variation depending on who is living in those neighborhoods, right? A limitation of just using our data when it comes to race and ethnicity is that not all claims data comes with that information. And our friends at Medicaid are really good at it. Medicare is really good at it. The commercial payers are not as good at that. That's something we're always encouraging them to do. But that data is a little incomplete. I'm talking about like 50%. So that's always sort of something we bump up against, which is why it's nice to be able to marry it with the American Community Survey because we can just pull the demographic information from there. So yeah, that's my dream, Maya. I think we could definitely expand this to look at other kinds of disparities for sure.
Thank you.
Hmm. There's a message in the chat.
Yeah. Do you want to go ahead and take it, or I'll read it to the group?
Yeah, let's read it. You can read it to the group. Sorry, I don't want to take your
Perfect.
moderating role
No,
here.
thank you. I had the chat, it just didn't scroll. So
No worries, you're fine.
yeah, what are the thoughts and reflections on this from your partnerships and stakeholders? Are there any conflicts, and if so, how are you navigating them?
So this is really a great question. With public data, there's always conflicts because we serve everyone, but everyone, all those change agents I listed in the beginning, sometimes have different agendas and different priorities, and they oftentimes are in conflict with one another. So this report is nice because it does come from a legislator, and so there's that level of that level of understanding. And we did actually get to present this data at the wildfire subcommittee for the representative that requested the data. And we had a really great conversation about how they could use this data in the future planning policy, and really like when we're thinking about emergency management and resources and how resources are allocated and where they're allocated. In particular, data like this would be really, really helpful for them to have, and understanding that there are particular groups of people that are impacted more severely in these moments, in these pollutant moments, than others, and sort of figuring out how to get those resources to the right people. Oftentimes, when they were talking about like emergency management is very much like in the moment, what are you doing to put the fire out? But there's not a lot of thinking about the long-term effects, right? Because these pollutants can continue to stay in the air well after the fire is gone. And so, and the wind blows them, right? So it's not always just one county specific area. So that it was a very collaborative conversation. And I think across the aisle, this was a bipartisan committee. It really was not a hot button topic. There's other things we've done. We did a report on firearm firearms injury analysis the same time we were doing this. That's a different ball game, right? So this was not it's not as hot buttoned, it's not as complex. I think everybody wants to give people healthcare and meet people where they get healthcare to them and deliver healthcare to them, not at the emergency department. And understanding that these groups are more vulnerable to that, and getting them what they need well after a fire is done is important, I think. So, oh, I don't know, Madison, if they were trying to say something. I had to jump off, but thanks for your question. Very good question. Appreciate it.
All right, we have another question from Hannah Peterson. Can you speak a little more to the seasonality of your findings? Did you say winter months had higher rates of ED utilization too?
Yeah, so I think that's sort of the general finding. And I think if you work in healthcare, you know that there's an ups and downs on utilization. So for ED utilization, there's a higher spike in winter months, right? So when there's cold and flu season, we're seeing spikes. I worked at Children's Hospital for a very long time, and we'd get like the census data, we'd sort of see like it's red and it's January or February, so you could see that spike. And so I did want to make that clear that um, these groups see a spike in general, regardless of the air quality. They're the ones going to the emergency department the most, and we see a spike overall in all age groups during cold and flu season. So yes, that's something to note. But the piece that we found in our analysis is that we're seeing higher rates than the normal winter months when there are ozone wildfire pollutants in the air for those age groups. Thanks, Hannah.
Yeah, that was a great question because there's sometimes an inversion, right? And I don't know if in all places in Colorado that is the case, but in some places in the wintertime, the air pollution actually gets trapped more, even though we associate
Exactly.
late summer and fall with
Exactly.
fires. Yeah.
Exactly. So we're seeing that those things are still lingering in our air and they are not going away.
Um, if there are no other questions, we can either decide to wrap early. I did have one question about the ozone, like how you decided what a spike was.
Yeah.
Um, I wasn't sure that that was something that was defined yet, if there was like unhealthy ozone and
Yeah, I think I think there's been some back and forth on what uh if it's tolerable, right? Or when it becomes a health problem. That number in particular did come from our external resources from the EPA. So that's kind of what we used. But I do know there is still a lot of research and uh, discovery in that area. And yeah, that is an area that is a little out of our realm of understanding. So we did rely sort of on what was publicly available, but I am sure there's some environmentalists, scientists that could speak to it more clearly. But I know that that has been controversial, that threshold. So
well, that's super helpful. Yeah, so does anyone else have any other questions? Again, feel free to unmute yourself or drop it in the chat. I'll give it a couple minutes and then we can wrap.
I'll just throw our website link real quick in the chat.
Perfect. Yeah.
And this is where you can get all of our public reports. And if you have any questions afterwards, I will also throw my in the chat. If I can remember my email address, that'd be good.
Mhm. All right, thanks, Claire.
Yeah.
Before we wrap, I just want to say thank you all for attending this session and for engaging with us. I just have a couple of announcements before everyone heads out. The slides and additional handouts the speaker has provided are available on Sketch, so you can refer to that. You will receive a conference evaluation form via email after the conference is over. As data lovers, please fill that out. Even if you only attend a portion of the conference, it is very helpful for our planning committee. And we all have about a 15-minute break before the next session begins at 2:45. And at that time, there will be 3 sessions to choose from. And you can see the full schedule on Sketch if you are not sure what's coming up next. So thank you all.
Thanks, everyone. Bye.